to the Home of Medicine podcast with me, Dr. Amy Burbridge.
And me, Dr. Ben Lovell.
Hi Ben, we've had a bit of a break over Christmas and New Year, but I'm back with a really interesting case for you. Are you ready?
I'm ready, yeah. Tell me your case.
Fantastic. So I've got a 74-year-old gentleman who is diabetic and hypertensive and well controlled on medication. Now, he's normally fit and well aside from these comorbidities, and his family had seen him at around 4:30 in the afternoon at home, and they said he was well. Went upstairs for a bit of a sleep, and around 8 p.m. they thought, actually, we probably need to wake him up because he needs some food. So they went upstairs to wake him up. They shook him, and he woke up. However, they said when he woke up, he appeared a little bit confused, and they described some shaking of the upper and the lower limbs, both sides. This lasted a few seconds, they said, and self-terminated. They were really concerned about this, understandably, and they called 999. The 999 crew arrived, and their documentation in the ambulance notes, which I always find is incredibly helpful, says that one thing that was particularly of note is that the left arm had no tone, was completely toneless, and also had very little power, very little movement in the arm. Didn't really have any comments on the legs in the notes. He was also completely non-verbal. They did comment a few times that his blood pressure was high, at 183 over 111, and they noted that his glucose was 22.8, but had normal ketones. That's all I'm going to give you.
Okay. So we have a 74-year-old man who had an episode of something at home on waking from sleep, which was observed to be shaking, a brief shaking of all four limbs, I think.
Yes. Yeah.
Which lasted seconds.
Yeah.
And then subsequent to that, he was non-verbal and had what appears to be paralysis of the left arm.
Absolutely. Yeah.
Okay. So I'd be interested to know a few more details about this shaking episode because I'm wondering whether this is epileptic or not. You didn't mention it, but does he have a background of epilepsy?
No.
Okay. So has he had a first fit? Things I'd be asking the family when it's really useful that they were there because the observer history is actually really, really informative when you're trying to work out whether someone's had a seizure or not. I'd be asking about what we call the semiology of the episode. So what were the signs? What did it look like? So I'll just clarify with them. Did he shake all four limbs?
He did. All four limbs were shaking.
And how long exactly do you think it lasts for? Less than a minute?
They said it was definitely less than a minute. They didn't time it, but it wasn't very long. They actually said a few seconds, but it's very difficult to, I guess, in a situation, an emergency situation, time is weird.
Yeah, that's true. Yeah.
So it's very difficult to say exactly what it is.
Was he incontinent of his bowels or his bladder?
No.
Any tongue biting that they noticed?
They didn't notice anything, and it wasn't commented on by the ambulance crew.
Okay. And then I'd ask a little bit about recovery time. So afterwards, they said he seemed confused. I wonder if this is a post-ictal period. So when they say confused, do they mean he because he wasn't speaking, he was nonverbal, or did he seem to be completely disoriented? Do we get that kind of nuance from the observers?
It was difficult to say, but they said that the ambulance crew and the family said that he was completely nonverbal.
Yeah. Okay. So it may be that he was completely oriented, but he could not speak.
Absolutely.
Or it may be that he was confused and his being nonverbal was part of that.
Yeah.
All right then. And during the episode, the shaking episode, I know it only lasted a few seconds, so it probably happened very quickly. But did they give any indication whether he was responsive or interacting with them? Was he looking at them or making sounds?
No, they didn't. To be fair, the sound wasn't commented on, and I don't think that question was asked at the time. But you've raised a really good point, actually. I've got family members who have epilepsy, and when I was younger, I knew that they were having a seizure because there was a very specific noise that they would make.
What was the noise?
It was almost like a grunting, like a pre-seizure, like an oral noise, like a grunt, and then the seizure started.
Wow.
So I've had first-hand experience of that. However, they didn't comment on this gentleman and any sounds, and to be fair, it wasn't asked.
Okay. So what my thoughts are right now, before we get some more history, is did he have a first fit? And now he's post-ictal and maybe has a Todd's paresis of the left arm. I've got to say, I've never seen a Todd's paresis affect just one limb before. It's usually a hemiparesis.
Hmm.
But okay, and is this part of his post-ictal phenomenon, or has he had a stroke?
Okay.
So a stroke would cause sudden onset limb weakness and aphasia, which is what
Yeah.
it sounds like he has here. How do I tie that all together with the seizure, though? Do you have a stroke and a seizure at the same time? Well, if you have an ischemic stroke, then that doesn't quite fit. If he had a spontaneous hemorrhagic stroke, which would be atraumatic, it sounds like, because you didn't mention any head trauma, that could have precipitated both a seizure and caused the acute neurology that we're seeing. So I'm sitting now with some kind of intracerebral event,
Yeah.
is my current thoughts,
Okay.
and I'd be assessing from that point of view.
Okay, fantastic. Now, I still hadn't seen the patient at this point. This was still in ED. The diagnosis that you've given there was not mentioned, and another diagnosis was given, but I'm not going to tell you what that is at the moment. Now, I'm going to give you a little bit more history. Prior to the admission, he'd had a 2 to 3 day history of coryzal symptoms, coughs, colds, runny nose, generally just feeling a bit run down and a bit virally. The rest of the family as well had also had similar symptoms. The family say that he had been not quite himself, and they describe a sort of a bit of a confusion, not really knowing where he is, but sometimes knowing where he is, and then just not being himself. And this was going on for a few days, around the same time as a coryzal type symptoms. So I'm not really sure what that meant, but could be delirium potentially that was going on in the background. Now, while this history was being taken, it's then documented in the notes in resus that there were concerns that he had some further seizure activity that lasted less than 30 seconds. They say that the arms and legs were moving in a rhythmical movement, but it stopped of its own accord. And the plan at that point was to give intravenous levetiracetam and intravenous coamoxiclav. Any thoughts?
Okay, well, the intravenous levetiracetam anti-epileptic seems reasonable. I'm not quite sure where the coamoxiclav is leapt in from. That we haven't talked about an infection. Oh, they thought maybe he had encephalitis. No, that's viral. Why were they giving it? They thought he had meningitis. No, no, this isn't adding up at all. So I'd be intrigued to know what the decision process behind the antibiotic was. I can't quite justify that with the data I have. They probably had different data, which made it a very reasonable choice to them. So that doesn't quite add up for me. Recurrent episodes. Okay, fair enough. He hasn't technically recovered in between each episode because he had this persistent neurological deficit. So I can imagine someone treating this as status epilepticus and treating with anti-epileptics, although normally we do give benzodiazepines as first line treatment for that. I'd be really interested to see this when I am told, oh, that patient's having another episode as a doctor in hospital. I'm like, let me
Yeah,
run, go. We got to see it. We got to see it because it just gives you so much information. What it looks like that there's something about seizures which you can sort of see.
yeah,
We did an episode, and maybe it's one of our first ever podcast episodes about how to tell the difference between an epileptic and a non-epileptic
it
attack,
is.
and
Yes.
we drilled down quite heavily into that, and it was quite interesting. Go back and listen to it, people, if you want to hear all those pearls of wisdom. But I don't think we're talking here about this man having his first ever non-epileptic episode. So I'm not trying to differentiate between that. I want to know whether this man's fitting or whether there
Yeah.
is another neurological process going on. And having eyes on that situation is really, really informative. So I'd be at the bedside having a good old gander if I could. I'm just trying to think about where this carmoxiclav came from. Maybe you'll tell me in a minute, but I guess if someone was worried about a central nervous system infection, there are two things we worry about: viral infections and encephalitis that can present absolutely as personality change,
Yeah.
seizures. I'd be looking for a fever. I'd be looking for elevated inflammatory markers. So I could see why they might give acyclovir. Bacterial CNS infections, we're really talking about bacterial meningitis. That doesn't present quite like this. That presents with meningism, headache, photophobia, and yes, you can, when it fulminates, you can get seizures and then horrendous problems with intracranial increased pressure and coning and things. But I've not got any of that flavor of bacteria from what you're saying. No one's mentioned any features of sepsis or meningococcus, which might go with that. Older people can get bacterial meningitis from other things like
Yeah.
pneumococcus, but
Listeria.
listeria, I've got in my head as pregnant women for some reason. But I think that, yeah, you've mentioned a prodrome of a viral. I'm forcing things to fit now. Has he got meningococcal pneumonia and he's now got pneumococcal pneumonia, pneumococcal meningitis? Not a satisfactory diagnosis. So
Okay.
I'm intrigued to know where the antibiotics came from, but I'm on board with the anti-epileptics.
It was fascinating then listening to you working through that because you had a really similar thought process to mine. Because I was trying to understand why IV coamoxiclav had been given at the point. I'm going to give you a little bit more information now. So, post episode, the second episode that happened in Resus, observations that were done. I'm going to go through the A2E assessment. So, the airway was patent, oxygen had been given because of the seizure activity. And on oxygen, 15 litres via a non-rebreathe mask, oxygen saturations were 98%, as expected. The chest was clear on auscultation, no signs of pneumonia, as you alluded to there. Does he have a pneumococcal pneumonia that led to pneumococcal meningitis? The chest was clear on auscultation, however, a chest x-ray hadn't been done at the time. Respiratory rate was normal for the patient. The blood pressure at this point was 195 over 121, so pretty high. The heart rate was 92 beats per minute and it was regular. Apyrexial. So the temperature at this point was 36.2. The glucose was 22.8
Okay.
in a known diabetic patient. There was nothing else of note on the rest of the examination. So following this second seizure-like activity, there was no incontinence of bowels and bladder, and there was no tongue biting noted. And there was no documentation of any eyes rolling back in the head or eye changes that sometimes people describe. And again, post-ictally, or whatever this episode was, the patient was a little bit confused, as had been pre the second episode. So nothing had really changed. There'd been an incident of 20 to 30 seconds of limb shaking, and really we're back where we were. Somebody did a venous blood gas, and the lactate was 5. pH was normal, everything else was okay. Rest of blood investigations show a normal white cell count at 5.87 with a normal neutrophil count, hemoglobin of 110, sodium 137, creatinine 96, electrolytes normal, CRP of 32.
Okay. All right. I'm still not sold on CNS infection. Let's talk about the high blood pressure. So you do get very high blood pressure once you've had a stroke. It's part of a physiological autoregulatory response to hyperperfused damaged brain tissue. So if you go and work in a stroke unit in a HASU, you see systolics up to 200, which is a sort of post-stroke response. So I'm going to put that in my stroke pile because we still wonder if this is what the acute event was. Also, seizures can manifest as a very late stage complication of hypertensive encephalopathy. So if someone has uncontrolled hypertension, one of the signs of end organ damage, apart from the AKI and the heart failures, you can get delirium, encephalopathy, basically, which can manifest as seizures if it's not controlled. Although you normally see that with really high blood pressures north of 200, 220. So his was what, 190 over 120?
Yeah. And it had been around that throughout the whole time. Known hypertensive,
Yeah.
he takes his medications. Family thought that he'd still been taking his medication, so weren't concerned about that he hadn't been.
I mean, and we could just describe that BP to stress of acute
Yeah,
illness and having had
absolutely.
a seizure and being in hospital.
Yeah.
So I wouldn't be prioritizing treating that blood pressure as my number
Okay.
one.
Okay.
I'm more worried about the fact this man is mute. He's aphasic and has a paralyzed arm. I think he
Yeah.
needs urgent brain imaging.
Yeah.
The white cells, I think you have about 5. The CRP is 30, which is neither hither nor thither. It could be a stress response. Doesn't mean there's infection anywhere. And you
Yeah.
said he's afebrile, I think.
Afebrile. Yeah.
So I'm not reaching for the lumbar puncture needle at this point in
Okay.
time. So I'm going to put that on the back burner. First of all, I want imaging of the brain.
Okay. So you want to do a CT head?
Yeah. Yeah.
Yeah.
And in my hospital, we do a CT stroke protocol, which is a CT angiogram. So I'd be looking for any large bleeds that pick up. And
Yeah.
also, if there is an established stroke, it could pick up a large infarct. A acute CT head for an angiogram phase, it won't pick up the beginnings of an ischemic stroke. You need an MRI for that. but
Yeah.
that's not usually practicable at the front door. So
Yeah.
essentially, had to rule out any bleed and any contraindication to thrombolysis if we were going to go down that road.
Yeah, absolutely. And in our hospital, we have a slightly different protocol, but we did a plain CT head, which gets done very, very rapidly, which was normal.
Mm,
But
mm,
again, like you alluded to, what a plain CT head is good at doing is it's telling us that there's not probably been a large acute bleed,
mm,
see, that would preclude thrombolysis. But what it
mm,
doesn't do in all individuals is tell us if there is an ischemic event,
mm.
an infarction.
So I think at this point in time, to summarize, we have a 74-year-old man in resus who is aphasic and has acute neurology in limb paralysis, slightly high blood pressure. He has had several witness episodes of what we think are seizures. He has had a preceding illness of mild cognitive impairment, which is unusual for him, and a viral illness. And we have a normal CT head. And the only remarkable thing on the bloods, I think you said, was the CRP of 30. Everything else was okay.
Everything's completely normal, apart from
Okay.
this BM of 22. So I don't know, would you rush in to manage this? Ketones were okay, he was not acidotic, sodium was okay. So we're not sort of thinking down the hyperosmolar hyperglycemic state, although that sometimes can also have a little bit of confusion presenting as well. What,
Okay.
how
So
would you manage this gentleman at the moment
in terms of the blood sugar,
in terms of everything?
right, easy stuff is I'd make sure that we had a safe airway. I make sure all the vital signs were okay.
Yeah,
I probably would look at the blood sugar and think this is a man who has got a high blood sugar. He's not going to be eating for a little bit of time because of
yeah,
issues. I would just start a sliding scale here just to get his blood sugars under control. Am I absolutely sure he hasn't got HHS? I work out the serum osmolality
yep.
by adding together the potassium and the sodium, multiplying that by 2, then adding on the glucose and the urea. I'd be surprised if he did with the sugars of 22. Normally, it's sort of when
It's a
it's
lot higher,
high,
isn't it? Yeah,
50 or something
yeah,
when you get HHS, which could cause a lot of cognitive impairment delirium. But I think I would control that with a sliding scale in the first instance, just
yeah.
as maintaining homeostasis. With all the other things I've mentioned, I wonder if it's time now to start looking more closely at CNS infection. I probably would have a discussion with the stroke team on call and just give them the history and say, is this someone you would like to manage in HASU because they've got acute neurological deficit, which might be appropriate for thrombolysis, or they might need an urgent MRI plus or minus LP. Maybe this is to be all managed together would be done in neurology. But if they said, look, this doesn't sound like a stroke to me, you treat as you see fit. I think the time has come to start thinking about whether or not we need to do a lumbar puncture and start some acyclovir to cover for viral encephalitis. Maybe this viral infection you had in the preceding days, that has been a cause of a viral encephalitis, and that presents us with seizures, acute neurology, and aphasia. So the only way to know that is to do the LP, and I'd be looking for the white cell count, and I'd be looking for elevated white cell count, which are mostly lymphocytes, a lymphocytic CSF, basically. And I'd also be sending it for HSV PCR.
Okay, excellent. So I was handed this gentleman over on a Sunday morning in handover to say that there is a 74-year-old gentleman who's got encephalitis and you need to do a lumbar puncture on them. And I always get really twitchy when somebody says I need to do a lumbar puncture
Yes, so do I.
because I like to make that decision myself. I think I've alluded to this before, but I'm a bit of a control freak. And if I'm being told to do a lumbar puncture, which is an invasive investigation, I have to have good reason for doing this invasive investigation. In addition to that, I need to make sure that the reason I'm doing the lumbar puncture is good enough. So this diagnosis of encephalitis, where did it come from? Are we treating for encephalitis? It's the same with subarachnoid hemorrhages and lumbar punctures, but I won't go down that route because we could have a 2-day podcast, I think, if I started talking about that. But I was told to do a lumbar puncture, and I was like, well, I'm not going to do a lumbar puncture. That's my first response. If somebody says do a lumbar puncture, my response is I'm not doing a lumbar puncture every time because I need to take a history myself and examine the patient.
Okay.
It's a weird thing I've got. I don't know. Maybe the fact that I did neurology and did about 3 million lumbar punctures when I did a neurology placement. But I'm always really cautious about doing LPs. So I went to see the gentleman And it was a bit later in the afternoon. And prior to this, my resident doctor who was working with me that day had done a ward round and seen the patient, took a history and examined the patient and said, it doesn't feel like encephalitis. It's just not fitting the picture. The bloods are normal. There's no pyrexia, just doesn't fit, and has got a dense paralysis of the left arm. And actually, on neurological examination, the left lower limb as well was also weak. So I went to see this patient and there was nobody with the patient, so I couldn't get a collateral history at that time. And he was unable to communicate with me and could have been aphasic, but wasn't really very awake. I couldn't assess whether he was confused or not, to be honest. So at this point, I was like, I'll try. I couldn't do a history, so I did a thorough examination. So I went back to MRCP PACE's neurology level examination. I was so tired by this point that this was going to, and when you get to that point of the day and seeing a patient takes 1 hour instead of 10 minutes. So
Yeah.
I examined the patient and I clearly identified a dense left hemiparesis. Left arm and the left lower leg, there was nothing there. To me, this was a stroke until proven otherwise.
Yeah.
Personally, that was what I thought. However, everybody had told me he got encephalitis. He was on acyclovir at this point. Another team, the neurology team, had also reviewed the patient and said, this is encephalitis, this patient needs an LP. The stroke team had said, this is probably encephalitis, needs an LP, do an MRI. So, MRI, when I assessed him, the MRI hadn't been done. And my diagnosis was, I really feel that this is a stroke. And my plan was very clearly, I write in 74-year-old male, left arm weakness, left limb weakness, possible seizure activity, although not witnessed myself, some postictal symptoms. Could this be delirium? Hypertensive and known diabetic, no atrial fibrillation noted on the ECG, CT head was completely normal. Is this an infarct? Double check the glucose because this is HHS, and my plan was for an MRI, aspirin, we'll probably need it, rectal aspirin, monitor the blood pressure, continue the anti-epileptic drugs at the time, not for lumbar puncture currently because I didn't feel that encephalitis was a possibility, and I stopped the antibiotics.
Well, why did the antibiotics come on? Did we ever work that out? What was that?
So it was for CNS infection.
But comoxiclav isn't even the right antibiotic for a CNS.
Yeah, I'm not sure why
Okay.
comoxiclav was chosen. So I'd
Okay.
said not for an LP, and I'd said to do a HIV test. Unusual signs and symptoms, I always find it's quite helpful because I've had some patients who are HIV positive when we least expect it. So I think it's in difficult cases. So I did a HIV test as well. And I basically got pulled apart and said, I don't understand why you stopped the antibiotics and the acyclovir. You need to carry on with these. This gentleman's got encephalitis until proven otherwise. And I was like, I don't think he's got encephalitis. I think he's had a stroke until proven otherwise. And we had a little bit of a heated debate on the ward about what the right thing to do was.
Pulled apart by whom?
By the specialist team, the neurology department.
But we're specialist teams.
So this is going to be really interesting, and maybe what we might say here is a little bit controversial. So
Okay.
I got quite upset actually by this because we'd asked for some intervention from a specialist team, which was neurology, fantastic, brilliant, and they said that they were the specialists in this area, and this gentleman had encephalitis, and it wasn't an infarct, and that they were to continue the acyclovir, and they were going to discuss with their consultant. And I turned around and said, I'm a specialist in acute medicine. I know how to manage and deal with encephalitis, and I'm a consultant too, and this is my management plan. And the response was, well, I need to talk to my consultant. I'm going to report this to my consultant. And I said, yes, I understand that, but I physically just spent nearly an hour with this patient. A long amount of time taking history and examination, probably to the resident doctors working with me were probably pulling their hair out by now going, oh, she's been in there for so long with this patient. But I really wanted to make sure I got the diagnosis right. And I was 99% sure that this person did not have encephalitis. Gut instinct, normal CRP, normal investigations, no pyrexia. And yes, you mentioned before, the signs and symptoms can also happen with encephalitis. But with the hypertension, I just felt like a stroke. The MRI was then done and reported, and the MRI showed acute restricted diffusion defects, multiple foci, and the right frontal and parietal cortical surfaces consistent with acute infarction and ischemia. No space-occupying lesions, no hydrocephalus, and age-related involution. Please speak to an acute stroke physician is what it said at the bottom. That was my plan. However, the specialist team still felt that this could be encephalitis.
Okay.
And I was still being told to RP and do a lumbar puncture, and it was really, really challenging situation. I've been at work for 11 hours. The resident doctors working with me were absolutely wonderful. And they were like, Amy, you're so tired. You've seen so many patients. Can I get you anything? Something we can do? I was probably getting a little bit ratty, as you do towards the end of the day. But I was so convinced this wasn't encephalitis. And I kept being told to manage this encephalitis and to restart the acyclovir. And I didn't restart the acyclovir. The next day, somebody else saw the patient, restarted the acyclovir, basically did everything that I'd not wanted to do. Any thoughts?
Loads. So, as a side note, this podcast is also available on YouTube if you like to look at us. And those of us who've been watching along will have seen the fantastic array of faces I've just been making over the last 60 seconds in disbelief and confusion. Right, where do I begin? First of all, has this patient had a stroke, or is it infection needs an LP? This is so crucial because if we treat someone for a stroke with aspirin and even clopidogrel, we can't do an LP because you can't put needles in some neuroaxial interventions. And well, I think aspirin is a soft no, clopidogrel is a hard no. So it's really important to get it right. We can't load someone on antiplatelets and then do an LP. That's dangerous. And the other timing is MRI versus LP. So if you want to do an LP and an MRI, you should really do the MRI first. If you do an LP, particularly if you take off a larger volume of fluid, if you do the MRI, you get false signals. You get leptomeningeal enhancement due to pressure changes. So it can give you false findings. So it's good practice the MRI first. So there is an order of things you have to do here. And you can't just do them one after the other. So I would have been the same as you. If I said I want an LP and I want to do an MRI, I would have said, let's hang out till I get the MRI first. Cover with acyclovir if you like. I don't have much of a problem with that. So acyclovir can cause an AKI in a very small minority of people. That's the only sort of downside with giving it empirically, but otherwise it's fine. But I would get the MRI first if I thought it was going to happen pretty quickly. It sounds like you got your MRI pretty promptly.
Yeah, it was really good. Yeah, absolutely.
At the point of the MRI result, which confirms stroke, I would then stop. And I'm really interested to know why it was thought that they had proven strokes on what I assume is DWI, so diffusion restriction imaging, and at the same time also encephalitis. That would be one for the history books, and I'd be really intrigued to know why they thought we still needed to do that rather than getting on and treating the stroke. This guy's probably, well, he definitely's fallen out of the thrombolysis window now, isn't it? So it's all about how we manage secondary prevention and try to get early interventions that are important and available on HASU, such as feeding, in early physio and OT and all that sort of thing, and aggressively managing all the other parameters, which is what stroke medicine is for. So I would have done the same with you. I would not be treating or looking for infection now I've confirmed stroke, because one pathology is better than two. And that one pathology has nicely explained quite a lot of stuff.
Yeah.
Was there stroke on the appropriate hemisphere to explain his symptoms?
Yes.
So it all added up neuroanatomically.
Yeah.
Interesting. And I think my final thought is, whose name is above that patient's bed? Mine. And I'm not saying that because I'm egotistical. It means that I'm the one who has to do all the risks and balancing and then work out what the least injurious thing is, because of course I'll be asked to answer all of these decisions if ever asked to do so by in a medical legal aspect later on. I did see something on social media recently, and it was sort of I think it was a neurology doctor saying, I don't understand, why do people ask for our opinion and they don't do what we advise? It's really frustrating. And I almost did a reply, but I thought, oh no, I can't be bothered, saying we're really, really grateful and interested for your opinion on your specialty, but we are looking after the whole patient, and we might have sight of things that you haven't, looking at what your organ specialty is that maybe you don't have sight of. We've seen the patient on a daily basis, and whilst we value your input and we value what your priorities are, we have to weigh it against other specialties priorities and our priorities and the patient's priorities and come up with a decision. So please don't think we're ignoring or we're disrespecting any special advice that comes in. We take it really seriously, and it
Yeah.
definitely informs what we choose to do. But please understand, it is us who is choosing to do it. If you wanted to take this patient fully over to your
Of
ward and do what you
course.
want, yeah, we'll talk about that.
Yes,
And maybe
yes.
that's the
That's
right
very
thing to do.
different.
And
Yeah.
then you can do that. And then maybe you'll ask me for a medical review and for other aspects, and I'll come and give my advice. But
Mm.
whilst they're on AMU, and I really hope people don't think I'm saying this from a point of view of ego, saying I'm the most important person. It's just that I'm that patient's doctor, and I'm adducing a lot of evidence from specialists so I can come to a path forward
Of
which is
course.
right for my patient.
Of course.
And there's absolutely no disrespect intended if I choose not to do something that you've advised to do very strongly.
I think the frustration with me was, and I really struggle with this, is and I still perceive a complete lack of respect for acute medicine as a specialty. And it doesn't feel like we have as much respect as if I was a respiratory physician or a cardiologist, because I'm just an acute physician. And I don't know whether you feel the same as me, but I don't feel like I have that respect that some other specialties have. And that upsets me sometimes.
Yeah, I mean, we discuss this a lot. When we go to our society meetings, things like we laugh about it. We're a young specialty. We're only 20 years old.
Absolutely. Yeah,
We
yeah.
were we were the first ones, Amy. We were the
I
first generation of acute
know.
physicians.
Yeah.
And it's we were pioneers, but it's because we love general medicine. We love internal medicine. We love what we do. I love going to our meetings, the Society of Acute Medicine meetings.
Yes,
It's with people
absolutely.
who really, really enjoy their work. I've been to other society meetings and they're miserable. No, they always say, "Oh, we have the worst one." I think, and we go to our meetings. We have the best job in the hospital. It's so exciting. So we love generalism. We love general medicine, and
Absolutely.
we love the acute, the sticky end of general
Yeah.
medicine. The
Yeah.
first 24 hours of admission where things could go either way, and we get a lot of job satisfaction from that. But I definitely recognize what you're saying. I've had people say to my face, "Well, why did you not want to do a proper specialty then? Why didn't you want to do a specialty?" Blimey, it's a bit pointed, isn't it? And people do choose acute medicine now, and resident doctors are choosing their career. They actually, if their supervisor happens to be an ologist from another specialty, oh, why don't you do a real specialty? Why don't you pick an actual specialty where you can actually, develop and become an expert in that one area? I mean, good for you if that's what you want to do, but you have
Yeah.
to pick the career that's right for you.
Yeah.
And this is what's
Yeah.
right for us. And you did an ology. You were an
I
ologist for
did. I was an
starters.
ologist. That's true.
And tell me why you changed.
I changed because I just loved acute and general medicine. That's where my passion is. But a really interesting debate recently with a good friend of mine who's applied to do acute medicine as a trainee. And she's been told by another very good friend of mine and other people who are all ologists, don't do acute medicine. Acute medicine is rubbish. It's the worst specialty in the world. You're on take all the time. Nobody who's any good ever does acute medicine. And I'm listening to this, sitting there going, see, so is that what you think of me? Am I really that bad a doctor? This person who's applied to do acute medicine will be an absolutely wonderful acute physician. She has what it takes to be a fantastic, she's already a fantastic doctor. She'll be a brilliant acute physician. But for some of my closest friends to tell me it's like a dreadful specialty, I'm like, it's really hard to take. And as you can probably tell, it really frustrates me. And I think that's why in this particular situation, where we asked for a specialist opinion, who then was really dismissive of my knowledge and my decision making, was really upset me on the back of a very long day, being tired and not eating very well. But just to reflect back on the case, I did a little bit of reading around the incidence of encephalitis. The incidence of encephalitis in the UK is around a 5 in 100,000. The incidence of stroke in the UK is nearly 200 per 100,000. So stroke is way more common than encephalitis. We're going to see more stroke, and encephalitis is rare. I have seen it. It is rare, so I don't see it very often. But in this case, I think what had happened, and we talk about bias a lot, is the anchoring bias and that diagnostic momentum. Very early on in the process of this patient's case, the diagnosis had been documented in the notes by somebody, encephalitis. And that diagnosis had been carried on and carried on and carried on and carried on throughout the stay. I went in and retook the history and did an examination, spoke to the family, got a collateral history, was very happy that this wasn't encephalitis, with the looking at the full picture, and wanted to de-diagnose. I wanted to take that diagnosis away, and that was really, really challenging. when the diagnosis had already been given to take something away. And that's what I felt had happened there was diagnostic momentum and anchoring bias.
Yeah. It is hard to row back sometimes from a
Really hard.
diagnosis which has gained a lot of momentum. But it's
Exactly.
very satisfying to do, and it is very impressive to see other people do that, to sort of meet a very chaotic, complex clinical scenario and just say, snip, 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 that's not relevant, that's not important, this is the core issue here, and look, that's what's going on. And you sort of look at it with fresh eyes, and you go, oh, you're right, actually, it is a stroke. I'm not sure why we went so far down encephalitis avenue with this particular diagnosis, but because you get invited down it is the honest answer.
And
Um,
I think that's what had happened. And I think as
yeah.
acute physicians, one thing that we can do really well is look at the whole patient and take that history, do an examination, and go, actually, I've seen, I don't know how many patients I've seen in the last 6 months. I mean, I'm talking hundreds, thousands, maybe.
Mhm.
I've seen a lot of people. I feel that I've got the experience and the confidence to say, actually, I don't think this is encephalitis. I've got enough reasons why it isn't. I haven't got any reasons to suggest why it is, but I've got a massive reason here to suggest that it's a stroke. The MRI is saying it is, and the clinical symptoms are saying it is, and the blood pressure's telling me that it is.
You've got the diagnosis. You got the diagnosis of a stroke. So I mean, I would love to have said to them, I don't understand what's pushing you forward to
Yeah,
encephalitis now once we've got an alternative diagnosis, which fits everything
it's everything.
beautifully, the perfect puzzle piece. It all
Yeah.
comes together.
But I do wonder whether it was that diagnostic momentum because you're told encephalitis, 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 like you say, you've gone so far down encephalitis road that that's it. It's really hard to turn around.
It is, but you did it.
I did it. I do that. I seem to do that quite a bit, and one day I think I'm going to get into trouble for. But
And
anyway,
how is the patient now? Do you know?
yeah. So a couple of days later, had a MDT, stroke MDT with neuroradiologists, and the diagnosis was infarction. No evidence of encephalitis. Acyclovir stopped, and the management then was for the stroke. My issue here is because everybody was obsessed with encephalitis. I don't feel she received the stroke care she should have had. He should have had, sorry.
I think that the other thing I was going to say as well is sometimes just doing path of least resistance when you have run out of energy and you've run out of stamina.
Mm.
Um, fighting against well, not fighting, I suppose is a stronger word, but choosing to take a different path to what people are saying takes a bit of energy. You've got
Exhausting.
to keep explaining yourself and you've got to document very carefully. And even if you have like a resident doctor saying, so they've come and suggested this, I'll get it done, no problem. Are you sure you don't want to do it? It's not easy just to say, yep, crack on, crack on.
Absolutely.
I'm not
Yeah.
on call tomorrow, so you let's crack on and do what they've said, and then the next person can pick it up, and then I can be out of here, and we can see the next 9 million patients and move on with the ward round. It
Yeah.
takes more energy to say no. We're
Absolutely.
not doing that. We're going to do things this way, and I'm going to explain very clearly why I want to do it. And on another day, you might simply have not had the fight to do that. You might have said,
Uh,
okay, whatever they say, just follow their advice.
yeah.
Um, because we don't have the resources, time wise or energy wise, to pick this particular battle, to
Yeah.
fight this particular battle.
That's true. And I don't know why on this particular day I chose to do it because some days, like you say, exhaustion, number of patients deems that you don't do that. It was just food for thought. There was a lot of interesting things. Me and the resident doctors I was working with that day had a bit of a debrief about the case afterwards, see how, what things they would have done differently, what things maybe if we saw the case again, we'd do differently. But it was, yeah, interesting on all sides.
It's an interesting case.
Yeah.
And the way if we look at it now from the end, now the dust has settled, someone came in with an acute neurology, aphasia, hemiparesis,
Yeah.
sudden onset,
Yeah.
and an MRI showing a stroke. You sort of say, well, what's the debate here? Why is this a
Yeah.
podcast episode? Because
Exactly.
talk about a
Exactly.
straightforward diagnosis,
Yes.
but it was not a straightforward road from A to B.
No, absolutely. Thank you so much, Ben, for your insights are brilliant as ever. And please, 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 if you are enjoying the podcast, please rate, review, tell your friends about the podcast. We are now on 250,000 downloads. So this is a labour of love for me and Ben. So please continue to listen and send us your, I don't know what I'm saying now. Maybe delete that bit out.
Send us some love.
Send us some love. Exactly. Exactly. Thanks for listening.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.